I'm excited to welcome back into our studio our special guests, as I really love their presentations and I'm really excited to hear them discuss some of the questions that we're all going through as NET patients and caregivers. So first we have Dr. Mark Lewis, who's a medical oncologist from Intermountain Healthcare and also living with NET. We also have Cindy Lovelace, who's the founder and past executive director of the Healing NET Foundation, and Josh Mailman, who's the president of NorCal CarciNet. Thank you all for joining us and for your amazing presentations. I know that much of what you said resonated with me personally, and I'm excited to pick your brains a little bit more and delve a little deeper in some of the things you brought up. So if you'd like to, let's first talk about goals. Josh mentioned goals. That is the G in the goals acronym, decide on a goal. And Mark, you also mentioned that something we all want is longevity and quality of life. So those sound like great goals. There's just a lot to choose from when we're thinking about goals. So how might patients go about deciding what their goals are? Mark, let's start with you.
Yeah, one thing that we're supposed to do as oncologists, so as the physicians counseling patients, is we're supposed to be very clear, ideally from the very first visit, about the intent of treatment. And what I mean by that is we're supposed to be really unequivocal about, are we going to cure our patients or are we going to control their disease? And we know that for the vast majority of neuroendocrine tumor patients, cure is elusive. I, for instance, don't foresee ever being cured. So what that means is it's a different paradigm. It's really conceiving of this as a chronic illness, and then thinking, as you mentioned, Lisa, about longevity and quality of life. And I guess my first answer is those two things, thankfully, don't have to be mutually exclusive. There's a very long and commendable precedent in NET research about optimizing patients' quality of life. And usually when you do that, you actually see them survive longer. So the reason I'm bringing this up in the goals conversation is most patients come to me, and understandably, it's human nature. The first thing they want to know is, can you cure me? And then when I'm honest that I can't do that, that obviously shifts their expectations and changes their priorities. But it's entirely appropriate, especially in the context of a NET consultation, to talk about both things. How long can I live? And how well can I live? And I might let Josh speak more to that.
Yeah, Josh, you talked about deciding on a goal, and we talked in our support groups about goal setting. So what are your thoughts on this?
So I view it a little differently. I think it's a universal thing to want a longer life and a good life. So I think that's a universal, agreement of what everyone wants. But I think of goals as, what matters most, right? What do you want to attain? Do you want to be at your child's, graduation, whether it's elementary school or college, or their wedding, or some specific goal that is important to you? Because that will impact the type of treatments that you take, right? They're different treatments have different side effects or can get you past different humps. And understanding what goals you have, or I think, Lisa, you and I have worked with Red Wing enough times, what matters most to you? And I think that's really important to understand and to convey to your medical team what matters most. And that you set goals that you want to attain. I wanted to attain seeing my kid in first grade. Now I want to see him graduate high school. The goals change as you go through your time, your journey with this disease. But at each time, at each moment, you should think about what your goals for treatment are, and what your goals for living are. And I think they're really important to understand and clarify with your medical team.
Really good points, Josh. Really focusing on what matters most and that they can be fluid. Cindy, you shared in terms of your personal journey, you opened up with so much honesty and vulnerability about your personal goals and how you made decisions throughout your journey. So what are your thoughts about this?
Well, I think there's short-term and there's long-term goals. And, in the long term, yeah, I want to be living as long as possible and I want to live a good quality life. I want to be stable. So when I'm not stable, then the goal is to get stable. But, that's very simplistic. But I think that, we all understand, as Mark was pointing out, that this is a battle for a while. And so probably the rest of our life. So I think that, being able to accept that, and we'll probably get into that a little bit more in some of your other questions, is good. It's helpful. And I think short-term goals really need to be about quality of life. And if you are under treatment, what that looks like while you're dealing with any possible side effects. Just trying to keep a positive attitude as much as possible through that.
Yeah, thanks for all of that. And as we talk about goals and thinking about what matters most, Cindy, you brought up a really great point. Your first take-home point was education is a never-ending and necessary ally. Keep it active. However, at the same time, we know sometimes there's so much materials out there, so much content, that sometimes it feels like drinking through a fire hose. So where do people start, and how might patients and caregivers educate themselves? Cindy, I know you started with sharing some resources, but let's start with you first.
Okay, sure. I mean, I think you have to decide, where you're going to get the resources, and there's trusted organizations that vet and make sure they're providing the correct information, and that organization is not Google. So, patient conferences, being able to attend those virtually, as people do with LACNETS, as they are today. Obviously, that's easier than inpatient conferences. But, I think you have to find your place. You have to find where, the people you trust, who are also dealing with this disease. And there's a lot of resources out there, I think, in a lot of organizations, where patients are telling their story. They're telling, what they've dealt with, and maybe some tips for, getting through this. So I think all that is important. You just have to find what you're comfortable with, and where you feel like you're getting good communication, and therefore instilling trust.
Yeah, thanks. Some good tips there. Josh, what do you think about this?
So I know we will discuss boundaries at some point, but you also have to decide how much you want to be educated, or how much is too much, right? It's really good to have a basic understanding of your disease and what some of the treatments are. But on the other hand, it's also important to find your balance, to live your life, to know where it is you are comfortable with, and be okay with that. Yes, as Cindy said, it's important to find that trusted place, and the place to where you are getting informed information, whether it's through LACNETS or Healing Nets or NetRF, or there's a few nationally recognized groups, including my own, but it's really important to find that comfort zone, and to then go about and live your life, right? This is you could actually, between our three organizations, there's probably 1,300 hours of content available, and that's really too much to consume. And so find your comfort zone, get to where you want to be, and then augment as needed.
Yeah, education is not the end goal. The end goal is quality of life, as we've been talking about. So, Mark, I'm curious, as a physician and a NET patient, what you think of this, because I'm sure you see patients come in with too little information or education about their disease, and maybe too much. So what are your thoughts?
Yeah, I'm going to have two sides to this. So as an oncologist, I've signed up for lifelong learning. And we have a wonderful problem, which is progress, which means that we constantly have to update our thinking. If I practiced the way I was trained over a decade ago, some aspects of that would now be malpractice. That's how much things have shifted. On the other hand, I think Josh said it perfectly. Patients put a lot of pressure on themselves to be content experts, and really, as he said at best, they are the only ones that can determine what is the right amount of information for them. There's actually good research on this. We know that in cancer diagnoses at large, 97% of people use the internet, and 94% of people use Google specifically to look up their diagnosis. But it gets more interesting when you get into the rarer tumors. Patients with rarer tumors are actually more prone to being led to misinformation, and I think they're more readily exploited by search engine optimization, sometimes by parties that may be trying to sell them something. So the whole notion of support groups to me is so powerful, because it's like-minded and like-affected individuals who are already crowdsourcing reliable resources and information for you. It's not perfect, if I have any sort of bone to pick with support groups, it's not their existence, is that some members will over extrapolate their own experience onto other people. And I think if there's anything I know about NET patients is that we're all slightly different. That said, I think the benefits of support groups, both in terms of kinship and in terms of information sharing, far outweigh that slight risk of over assuming that someone else's experience will be your own. So I really like, obviously we're in the internet age. There's lots of resources online, as Josh said. You can quickly have a deluge. But I think using other people's wisdom that was hard earned to guide your own searches is really a wonderful thing to do.
Yeah, connection is important for sure. And another thing Cindy brought up in your presentation was to ask questions. And we do this of each other. We do this with physicians, of course. Ask questions when you don't understand the information and choices. Josh, you also shared about this in your 2018 Speaking Up series to write down questions before going to see your doctor. As you all know, we can have a lot of questions. So we also want to be wise and respectful of people's time. Last weekend at NANETS, one NET oncologist told me that he has a patient who will send him 15 questions at a time through my chart. So, and they could be really big questions. So I'm wondering, what suggestions do you have for patients and caregivers about how to ask questions? And, Mark, let's start with you as an oncologist and a physician dealing with
Yeah.
this.
I'm actually really glad you mentioned my chart because I think a lot of this can be done what we call asynchronously. It can be done through secure messaging, which is basically email built into the medical record. Your time with your physician that's face to face is incredibly valuable. It's literally commodified. Your doctor's office runs on a very, very tight schedule indeed. And so I think you want to make sure you're getting the most out of these visits. Now, what I have found really helpful is when patients come in with a deliberate intent. There really is no such thing in my mind as a routine visit because I want to make sure that A, they're healthy as best I can tell, and B, they're getting their questions answered. There are limits to how much of this back and forth messaging you can do within reason. 15 questions per message is a lot, but it's okay actually to use these channels, which are now increasingly available and quite secure in most cases, to communicate with your doc between visits. A question might come to you in the middle of the night. I frequently see messages from my patients at 3 a.m. and then I answer them when I can. It's actually a lot more helpful, I think, phone calls sometimes because there's actually a written record that we both can refer back to.
Yeah, thanks for that. Josh, I'm wondering what you think about this since you dealt with this in your Speaking Up series.
Sure. I mean, we dealt with it all the time. I think one of the most important things is to prioritize your list. Try to come up with the top five. Writing your oncologist 15 questions every time is a little rough, but come up with that top five. Prioritize what you want to learn about, what's important to you, what you really want to take away. So that's really important, and get that down. When I go, I write that list out before I go into the appointment. I also record the appointment. I ask for permission to record the appointment as well. As Mark said, when you do it in my chart, there's at least a written documentation of it. But if you do it in the appointment, you and your caregiver or whoever else attended with you might have a different interpretation of that actual answer. And so it's really important to also track what that answer is, and having a recording is a really good way to do that. Those are, kind of the important ways that I look at that. Prioritize, record, and make sure you don't, if you need to ask the same question over and over, that's okay, but make sure you try not to repeat questions and use that for good learning.
Yeah, really helpful practical tips. Cindy, what do you think?
Well, I have a short answer. I'm glad you asked the education question first, because the more you're educated about the disease, then possibly the less general questions that you have, and then your questions can be targeted to your specific situation. Whether you're getting ready to have a scan, or if you're getting ready to undergo treatment, or any of those places. I think it's important to base your questions on that, and at the same time try to educate yourself, because there's nothing wrong with saying to a doctor, hey, I read this, or I saw this, or whatever, what do you think? I mean, that's where a lot of questions can come from.
Yeah, thank you for that. Ties back to education. So Cindy, not to pick on you, but you had, so many good pearls from your presentation. You also mentioned surround yourself with doctors who really know NETs or are willing to
Yeah.
talk about doctors who really know NETs and get second opinions if you aren't sure. So here's a big question that, I know I get asked, I'm sure all of you get asked. How do you know if your doctor really knows NETs? And what practical
Yeah.
advice do you have about how to go about getting second opinions?
Lisa, that's a really good question. It's a difficult question because there are so many patients who don't have access to a NET specialist, whether it's because they're too ill or because they cannot travel, whatever the case may be. In some cases, they may be with a trusted doctor that they really trust, and, the doctor has told them that, they understand this or gives them some information. And again, I guess that's where the education part comes in. If you're pretty well educated on this, then you kind of know if you're in front of a doctor and they're giving answers that don't make sense with a lot of the trusted curriculum that you've looked through. And I also like to say that your doctor should be seeing some NET patients. They should be seeing NET patients on a regular basis. And there's nothing wrong with asking that question. How many NET patients have you treated and are you treating?
Thanks, Cindy, for sharing those insights. Josh, what about you? What do you think about this?
So I agree with Cindy that it's important to ask that question. How many NET patients do you see? Is this something you're comfortable treating? I also think it's important for us to take some ownership as well, to understand what the National Comprehensive Cancer Center guidelines are for NETs, so that you can actually see what at a baseline you should be treated with and understand whether you're getting that care. And if that care deviates from that, ask your provider why. And that's also a good time to think about seeing a second opinion if it's deviating and no one can tell you why you're deviating from what seems to be the accepted guidelines. Now, many NET specialists deviate from those guidelines as well, but they can explain you why they're deviating from and what's important about that deviation. So I think it's both asking that question of, do you see a good amount of NET patients, but also understanding what you should be treated with, or at a baseline what you should be treated with, so that you can make a determination if you need to go seek care elsewhere.
Yeah, thanks for that. And Mark, what do you think about this area?
Yeah, I'm going to answer this largely as a doctor. Actually, I'm kind of smiling wryly because I think there's far too much concern about bruising doctors' egos here. Patients are the ultimate stakeholders, and your health is yours. And as Josh said, there's a certain amount of responsibility that comes with that, but also you owe yourself, frankly, to be getting the best possible care. So I just want to peek behind the curtain very briefly. About 80% of cancer care in this country is delivered by generalists. And I do not use that word as an insult to their intelligence. My point is they have enormous breadth of practice. They are seeing literally every type of cancer in their office, which means that the likelihood of them having a huge number of NET patients is low. On the other hand, a lot of times when we talk about second opinions, patients, if they have the luxury, are traveling to sort of specialty centers or doctors that have accrued large practices of NET patients. And those two environments are different. About a quarter of my patients, for instance, have NETs, but I'm the exception, not the rule, in terms of how prevalent NETs are in a general clinic. So my point is, it is entirely appropriate, if you're interested, to ask your doctor, hey, how many NET patients do you see a year? I did the same thing, actually, when I was picking a surgeon. The difference there is there's a very, very defined surgical literature showing a certain volume of cases corresponds to better outcomes. It gets a little vaguer with net volume in the medical oncology setting, but I would say this. If you are even asking the question or bringing up the possibility of a second opinion and your doctor balks at the notion, they're probably getting a little bit too offended, in my opinion. Most of the doctors I know who do practice generally welcome having expert input, provided we respectfully relay our recommendations and don't condescend to them. This is increasingly a field where you need everybody. Like, I can't deliver care across my healthcare system without generalists, and generalists can't be expected to know every nuance of every cancer. So we need each other. We are working on that symbiosis, and it's entirely appropriate for a patient to ask their doctor about volumes and about referrals.
Yeah, thanks for giving us that insight, that peek behind the curtain. I'm going to circle back to the second part of the question about going about getting those second opinions, because that can feel overwhelming too to patients. So Cindy, I'm going to circle back to you first about what practical advice do you have about going to get those second opinions?
Right. Well, I mean, I think it's really important that you have all your information together. And that can be hard to do sometimes, but I'll mention Net Vitals because you've created that, and I think it's a great tool to make sure that you're keeping all your information in one place. Because if you do seek a second opinion, that doctor is going to have to see more than just you saying, "I want a second opinion." They're going to have to see your scans. They're going to have to see, the treatments that you've been through. So they're going to need a history on where you are at this point. And so I think it's really important to be prepared at any time to do that. And as far as seeking a second opinion, again, it depends on access and, if you're able to see a net specialist. But I do agree with Mark very, very strongly that if you have a doctor who is reluctant or gets upset because you want to seek a second opinion, that is just not acceptable. And, I would suggest that you move on in that situation.
Yeah. And I know, Josh, you showed us and told us about how you always get your CDs of your scans so that you're prepared as well. So, in terms of getting the second opinion, how do we go about getting that? And with issues of access, people wonder, do I have to fly or drive out of state or out of the area to get it? Josh, what do you think about how to go about getting those second opinions?
So this is a challenging question and answer in the moment we live in right now. Telehealth during the pandemic certainly took off and made seeing specialists across state lines rather easy without actually flying or traveling to them. That is changing. Different areas or different states have different rules about whether a practitioner can see you across state lines via telehealth. So there's no perfect answer for this right now. There are some that are still doing telehealth across state lines, but there's some who can't because the licensing requirements say that they have to actually physically be seeing someone at their offices or at least in state for telehealth. So not sure that there's a great answer to that one. In the olden days, you actually did have to travel pre-pandemic, and now we have some options depending on who the provider is. I think it's also as important to understand what you want to get out of that second opinion. Are you looking for a confirmation of what the treatment course is? Are you looking for a different outcome? And I think it's most important to try to understand the rationale of both your first opinion and your second opinion, and understand why they want to go down whichever route they want to go. Because if I look at the NCCN guidelines, for instance, for pancreatic neuroendocrine tumors, that the second line treatments, there's at least 8 of them, and if you blow out liver directed into the other 5 things that are there, there's at least 13 different options, and you could get 13 different opinions that each one would tell you one of those options. So it's not only important just to hear what the option is, but to hear the rationale behind it, because ultimately, as Mark pointed out earlier in this session, we're here for a long haul. We will be switching many different treatments, and understanding the rationale behind why people make decisions and will help you when you need to make that decision, not just this time, but further down the road, so you understand how your physician is making that decision. And so you're not just treatment shopping, you're trying to understand the disease shopping more. Because look, in our group, and I'm sure in yours as well, we're talking about second opinions, but I know people who have had third, fourth, and fifth opinions. And so the question is, I can tell you what those treatments are, but understanding the rationale and what fits into what matters most to you, going back to your goals and where you want to be, is really important. So you understand that rationale and just aren't shopping for a different treatment, because I can do that for you. I can give you all 8 to 14 of them, and I can give you no rationale for it, and you can say, well, he said to do that. It's understanding why you want to do something, and using that not only for this moment in time, but for future moments in time.
If I
Go
could
ahead.
comment real quick on that too, just follow up what Josh said. And I think I've said this before, a second opinion is not asking another patient to, kind of deconstruct what your doctor has said. I see a lot of that sharing online, and I think that, can be a real danger there. If you're having to do that, then, you obviously do need to be, seeking another doctor if you're not feeling confident in what your doctor is telling you. Now, I don't mean that you can't run something by a trusted colleague, that it's in or maybe running your support group or in your support group. Does this sound right? But, putting it out there in public and then asking other patients what they think about this doctor's opinion is just, I think that's fraught with a lot of landmines.
Yeah. And Mark, I see you smiling through all this. What are your thoughts about second
Yeah.
opinions?
Well, I guess I should put my cards on the table. I actually give a lot of second opinions. In fact, about 50-50 patients coming to see me to stay with me, and the other half coming to me for guidance, and then ideally returning to their first oncologist. And I want to respect that relationship. It's not just a matter of professional courtesy, but usually there's a reason that a patient starts with a particular cancer doctor. And often that's one of convenience in the sense of location and coverage. So we haven't mentioned the elephant in the room, which is insurance. A lot of times people are with an oncologist because they practice close to their home. So that's convenient, but also because their insurance plan dictates that's where they receive care. So for a host of reasons, I'm really careful. If I can avoid it, I try not to disrupt that alliance or that arrangement. And the best thing I think I can do, and Josh was alluding to this, was spell out both to the patient and to their first provider my rationale, my reasoning. He is absolutely correct. My record, by the way, for opinions is I think I've given a 12th opinion to somebody. And this person was traveling around the country and sort of on a tour, if you will, of net specialists. I suppose I should be honored that I was on the list. I kind of expected them to have a T-shirt listing all the places they've been. But what I find, without being silly, is I have seen patients get unnerved, and Josh was also inferring this. They get unnerved if they get different answers from different specialists. And there's a saying in medicine, which is that expert opinion abounds when there's an absence of evidence. It doesn't mean that we don't have support for our treatments, but the sequence, as he was saying, is sometimes unclear. It's not always set in stone. And that means it's okay. I understand why it can be upsetting, but it's okay if you get a second opinion or a third opinion or a fourth and nth opinion, and it deviates because, like he said, there is a lot of room for judgment. And as long as we're explaining the judgment, that to me is a part of informed consent. This is your body. You need to understand what's happening to it and why. So as long as the reasoning is there, I actually don't think there's a big problem with differences of opinion. But I really, really, really try to keep patients with their home oncologist. And again, once I have that relationship, that oncologist will often call me and say, hey, Mark, we're at a fork in the road with this patient's treatment. What should we do? And as Josh was also saying, that doesn't always require the patient coming back to me. That's something we can often do virtually the way we're talking right now.
Yeah, thank you. Really good points. I think we could talk for an hour just on this topic. There's a lot packed in there and really good insights. Thank you.
Can I follow up with Mark for 1 second?
Yes,
I
of course.
think that's a really good point. I think that, especially in the NET community, doctors do talk to each other when they are in forks in the road and are seeing something unusual and want to reach out, whether it's even planned to someone they are working with on a second opinion or just whether they're talking to a trusted colleague. I mean, many of the centers that we talk about have multidisciplinary teams that they bounce cases off. But honestly, as a group of oncologists and providers, this community certainly bounces tough cases off each other all the time. And that doesn't fall under the telehealth regulations.
Yeah, there's a lot of mutual respect and collaboration. Thank you. So Josh, you also brought up in your talk, one of the take-home messages and that goals was to set your ground rules. So what are some of the ground rules you set, and what other thoughts you have about this?
Well, ground rules are different for all of us, right? So one of my ground rules was when I was diagnosed and things looked very dire early on, I didn't want everyone to contact my wife or myself all the time and ask how things are or be afraid of it. So for instance, I set up a blog that my family and friends could subscribe to, and that I could push out the information rather than have them inundate family members or my wife or myself. And so that was one of my ground rules. The ground rules of I've worked with patients or talked to patients who actually don't want any bad news, and they've set that ground rules with their oncologist. It's not something I would do, but there are patients who have done that. So it's really setting those rules to how you want to communicate, how you want to receive information, who do you want to have contact you, how do you want to be contacted, what are those ground rules for engagement? Because we do have friends and family who want to help us all the time, and sometimes that can be burdensome, where we appreciate it and love it when they're bringing over meals or other things, but also we need our own space to work with and process what's going on, especially when we're in a treatment or an inflection point. So it's important to set up ground rules with family and friends. It's important to set up ground rules with your oncologist. I'm interested to see what Mark says, but I have been surprised about the difference. Like, I want to know everything, and I want to know it fairly soon and straightforward, much like, when you receive your information on your scan. Do you want to receive it right away, or do you want to wait till your oncologist is going to interpret it with you? I think that's about 80-20 in the NET space. In different disease spaces, that's going to be a different number. And so it's really important to work with every team that you have in this team sport and let them know what your ground rules are so they can help you with that as well.
Yeah, thank you. So I am curious to hear what Mark has to say.
Well, Josh, the scenario you bring up where the patient says, doc, never tell me any bad news, that's very tricky. You're very much shackling your oncologist with that, and almost, I would say, to the point of an ethical breach, because sometimes relaying bad news is actually a warning to someone, and you're trying to keep them safe. The other thing I'll say, and again, Josh was sort of hinting at this, is the game has changed in about the last year and a half. So with the passage of the 21st Century Cures Act, it is now a federal requirement that results be made available essentially as soon as possible to patients. And so what that's meant, I think it's very empowering, but I also think it is slightly dangerous in the sense that now bad news is not necessarily contextualized as part of a conversation with a doctor that knows you and cares about you. It can be as impersonal and dispassionate as an alert on your smartphone showing you that a scan has progressed or a biopsy has returned malignant. So the ways in which information is shared now, they're just different, and they don't always allow the framing of these conversations the way I would prefer. Like, if I know I'm going to deliver bad news to someone, I really try to set the stage. I try to block more time in clinic. Something as simple as having tissues nearby, making sure they're emotionally supported, maybe notifying my social worker. These are all the things that we do sometimes behind the scenes to prepare for those difficult conversations. I'm an oncologist. There's seldom a clinic day I have where someone isn't hearing something that they don't want to hear. So I think that ground rule is very tricky to abide by. Otherwise, I completely agree with Josh, particularly in regard to whom should be communicated with. There's actually a lot of legality there, typically written releases in terms of who we can talk to, because your privacy is sacrosanct. If there's any ethical standard that I think we all have to adhere to, it's confidentiality. So we're never going to disclose your information unless we have your explicit permission.
Yeah, thank you for that and that context to it.
I will say, since this is certainly a national and somewhat international recording, that there are some limitations to how that is done state by state. There are some state carve-outs that allow that data to be delayed. New Jersey, for instance, is 28 days by physician discretion. And so there are different things in different states that can change that. Just so you know, if you're demanding that your information be released right away and it's not, there are some carve-outs, but hopefully we'll all get there at one point.
Yeah, thank you. And Cindy, what about you? What are some of your ground rules?
I think it goes back to education, and there is a but with education. You know, trying to second guess or going too far into the future when you're, you know, having to make a decision, I think is sometimes not a really good practice. So, you know, and what Mark was talking about, all the access that we have to everything now, you know, I'm not going to panic. You know, I've got to remember that, you know, the type of neuroendocrine cancer that I have as a PNET, that there's a lot of options still out there that have not been, you know, undertaken at this point. And so my best practice is to not panic if I see something that looks off, but really ask my doctor or the nurse or someone about that if it causes me any type of concern.
Yeah, well, thank you. And speaking of panicking, I thought one of the highlights or one of the interesting things in Mark's presentation was when you talked about your roach problem in Houston and that whole idea of preparing to turn on the lights, knowing that if there's one roach, there are probably multiple. And as frightening as this is, I also thought that was a brilliant metaphor for our experience of going to have a scan and the anxiety we might have of getting a dotatate scan for the first time or after a long period of time and just having that scan anxiety. So I'm just wondering, how do you prepare to turn on the light? How do you deal with scan anxiety? And I know, Mark, you recently tweeted about your scan. So let's start with you first and then go to Cindy.
Yeah, so I guess I'll answer this both ways. One is as a patient, I'll be honest, I have my moments of sort of doubt and apprehension when I go in the scanner. You know, is this the time I'm going to have progression? Am I going to have metastases to contend with? But that's very fleeting. And most of the time I'm able to have stability and then get back to my life. So it's a punctuated equilibrium where most of the time I don't really worry about it. On the ordering side of things, though, and I'm really curious to get Josh's take on this, you know, the evolution of our imaging in the last several years in particular, in terms of its resolution, is remarkable. But you know, I tell patients all the time, you know, just because we can see more doesn't mean that the disease wasn't there previously. I know it's a double negative. And specifically, the example I used in my talk was in regard to bone metastasis. So our imaging now, modern somatostatin receptor scintigraphy, is so good at picking up skeletal disease. But thankfully, those areas are not always symptomatic. In fact, I think they are asymptomatic, meaning symptom-free, more often than they are painful. So I see patients sometimes in shock when they see their dotatate PET scan for the first time. On the other hand, I'm not entirely sure that's as clinically meaningful as we sometimes infer. And I don't want patients to worry more than they need to. So again, you can read your radiology report in many states right away. Realize that radiologists, for the most part, have not adapted their language to the patient as a consumer. It's usually still written with the expectation that a fellow healthcare professional will be reading it. So there is a lot of jargon in there that can be very, very alarming. One of the things I love to do with my patients is actually show them their pictures with all the caveats I just mentioned. I think pictures are worth 1,000 words, especially if they come in with preconceived notions about the scan. But if you're not comfortable with that, back to ground rules, you can tell your doctor, hey, listen, I don't want to see my pictures. So I know I've kind of covered a lot of ground here. As a patient, yes, skin anxiety is real, and I remember that when I'm ordering scans. I never order a scan unless I am reasonably confident I will be acting on the result, whether that means continuing surveillance or perhaps changing treatment. But Josh, I'd be really curious to get your take on where we're going with the resolution of these pictures.
We're going to get better. We're going to have more resolution. We're going to see deeper in, which, as you point out, is a challenge. But there's a couple things that we can do with that. So first of all, one way I look at scanxiety is anxiety is when we don't know about something. And I think with some of the work I've done with the Society of Nuclear Medicine, understanding imaging and treatment, you know, nearly 95% of those who are going to have treatment with a nuclear isotope get educated about that from their physician, from the nuclear medicine doc. They have time with that doc beforehand, before therapy. When it goes to imaging, we hardly ever, we get referred to imaging and that's it. We don't sit down and discuss what that imaging is and what the results might be and how to pre-digest the results before we see it, what to expect, when to expect it, You're absolutely right. Radiologists are reading scans. They're not your treating physician. They're not your treating oncologist. They're writing a report that is, factually based on what they saw for images before, but they are part of your team, but they're not your treating team. And so to expect that their report would be to the level of, what we are going to do with this information is a little beyond what that report is. On the other hand, since we don't really talk about imaging before we actually go to it, not necessarily you, Mark, but many physicians just order the DOTA scan,
Yeah.
but don't spend time saying, this is what we're looking for, this is what to expect, this is what your report might do, these are the things I will be looking for. It even goes so far as, we do some pre and post education seminars. And in fact, patients actually think that having a nuclear medicine imaging scan has more risks than actually having nuclear medicine therapies. And nothing could be farther from the truth, but because we don't educate prior to the scan and we just refer over, we set up this anxiety. So I think a lot of this can be eliminated or at least tampered down if the referring physician for imaging can take a little bit of time and educate on what we're doing, what to expect, and what the risks are of that imaging. And I think that would go a long way to beating anxiety. I do tell the the technologist who is setting me up that you've reached me at my worst moment in time, where I've lived whatever it was for that time, and that whatever will happen in the next 20 minutes or an hour is about to change my next pathway, and I'll be nervous until that moment in time. So they understand that I might be a little nervous, but yeah, I have my own DICOM reader and I read my own images, which may be good or bad, but we can discuss that. I know you were about to say something, Mark.
Yeah, if I can interject, Josh, so well said. I just wanted to go back to the why. So just like we were talking about earlier, if a physician is changing your treatment, for instance, or suggesting a change, the why is very important. I think what you're getting at, and you're right, it often goes unsaid, is the why of these scans. So if I can just briefly interject, because it might help with anxiety on a general level, the beauty in my mind of this receptor-based imaging is the lock and key hypothesis. So where receptors light up, these scans are different than a CT. A CT is just glorified X-rays that the computers put back together. It shows a structure. But arguably what these receptor-based scans give us, like DOTA PETs, is an insight into tumor biology, and that has a direct impact usually on treatment decisions, whether that's somatostatin analogs or PRRT. Josh, again, is a content expert on theranostics, the marriage of these technologies on both the diagnostic and the treatment side. But that, I think, is actually, I hope, a reassurance to patients, is that this is not just imaging for imaging's sake. It's not an academic exercise. The things that we find, we can usually action. So I just wanted to put that out there in case it helped calm some.
And I'm going to bring back to our last Twitter volley, maybe 3 or 4 weeks ago. We are all used to, and maybe not we, but physicians with FTG PET and even patients, higher numbers could be worse than lower numbers. And I think of that as SUVs, which are completely different for DOTA PET than they are for FTG PET. And I think you and I went back and forth and had this conversation about the number of people, and I should say the number of healthcare providers who misinterpret a higher SUV as disease progression and want to change treatment. And we need to work on that as a group. Yeah, no,
Yes,
I think we need to, we need to work on that in many different fronts to stop that misconception of just because you have a higher number, higher does not mean worse, it just means we know something differently.
Yeah, thank you, Josh and Mark. Cindy, what do you have to add to this?
Yeah, I just think, this is one of those areas where I recommend patients talk to other patients, because I think if there's a specific scan that you're getting, maybe it's the DOTA tape and you've never had that before, finding someone else who has had that and knowing what to expect, that can alleviate a lot of anxiety of not understanding what this nuclear med thing is and what are they going to do to me. So I think that's really important. The other side of that is not comparing scans, right? But going back to, having a net specialist, someone that you really trust, to help you interpret that scan, because it's all individual.
Well, I really enjoy talking to all of you, and I could talk for a long time, but let's just end on this last question. How do you, we're talking about a lot of anxiety and things that we're dealing with, thinking about present and future. How do you stay present and not worry about the future? And how do you hold on to hope? So, Mark, let's start with you.
Yeah, I guess I'll address the hope question. As an oncologist, almost every oncologist I know is an optimist. And that sounds strange because we're constantly confronted with people that have serious, maybe life-threatening illness. But I think all of us in our profession, and I can certainly speak to this personally too, have witnessed progress. I mean, a lot of the things we're talking about today, we couldn't have discussed in such detail, a decade ago. And again, Josh, as has been said, has been a real pioneer in sharing his experience with some of these more modern therapies. So my point is, I'm hopeful, but I'm hopeful with a reason, which is that I see things getting better literally all the time. Does that make things perfect for everyone? No. But does it mean, back to our dual goals, that we can expect patients to live longer and better? I think yes, in many cases. And the fact that NETs have this much investment of a brilliant international group of scientists and clinicians who genuinely care about patients, like Josh said earlier, if I could just show you the network of people that I get to work with, my colleagues, I think they are among the best people I've ever met in any context. They are a remarkable, remarkable group. So I know it doesn't make things better today. We all have our issues to deal with, but I've seen things tangibly improve. My father died of this illness in 1994, and his treatment, in hindsight, looks completely outdated and frankly barbaric in some of its toxicities. So if I had a time machine, one of the things I would do is go back and give him modern treatment, and I think that would have sustained him for longer. So I think I'm legitimately hopeful, both as a patient and as an oncologist.
Thank you so much, Mark. Josh, what do you think?
So I think I closed my talk with these two points exactly, although I did them in song, and I'll go back to those as well. How do you stay present and not worrying about the future? I do this with my son as well. We go to Jimmy Buffett, breathe in, breathe out, move on. There's always going to be another option, and you need to make a decision and move forward and not worry about the past. And so it's really important to understand what you're doing, feel confident about your decision, know that you'll likely get to make another one, and you go forward. So that's the first thing I think about. And then I often go back to the Warren Zevon interview with David Letterman. I watch it every once in a while. It's fantastic. His advice to those, actually to everyone, but to Letterman on when facing your own mortality is enjoy every sandwich. And I think that's the part about holding on to hope, or holding on to, we're here to enjoy life. And maybe another one, James Taylor, The Secret of Life is enjoying the passage of time. You really need to figure out what gives you joy, and live it, because that's ultimately what we're here for. And that's what I suggest.
Yes, yes. Cindy,
Well,
what do you think about?
I love that song. So just so you know, I'm not a huge Jimmy Buffett fan, but that song in particular was one I probably played a lot when I was diagnosed with neuroendocrine. It's one of my favorite songs. And it's so true, because what good will it do? If you don't focus on the present and focus on living your best possible life, then you're allowing yourself to be robbed of that joy, because it doesn't do any good to focus on what has happened in the past. And the future, you don't know exactly what option's going to necessarily work for you. I always like to be educated enough so I kind of have an idea, but things are changing, and that's good news. It's good news of all the research that we currently have ongoing in neuroendocrine. So, for me, it's a survival tactic to focus on the present. And I also like to use a sailing analogy, and I've said this before, is that we can't direct the wind, but we can adjust our sails. And the way you adjust your sails is knowing all the parts of the boat and what they do, and at any given time what you might need to do to adjust so forth and so on. Again, then knowledge and education is power. So I think that that's a good analogy for life, and I think it's a pretty good analogy for dealing with neuroendocrine cancer.
What a perfect metaphor. Thank you all for your wise words, the words of encouragement, hope, your insights. It's really encouraging to know that we have reasons to hope and legitimate reasons. And yes, we need to, think of what sparks joy and hold on to that and control the things we can, like directing our sales. Thank you all of you for all your time today and with the presentations, with sharing your insights. Thank you for all you're doing in the neck cancer community. We're really grateful for you, and we look forward to hearing you and seeing you again.